Greetings to all of our students, staff members, and off-campus partners, to our repeat visitors, and to our first-time visitors to the UWIHARP SHAZ podcast series. My name is Kelia Anderson, and I will be your moderator for this afternoon's session. And with me is Dr. Damian Bass and Ms. Chloir Springer, our presenters for today. Before we start, just to give you, our new visitors, a little background of what UWIHARP is and what we do here on campus. We are the HIV sexual health program here on campus, and we seek to positively influence the sexual and reproductive health and wellness of our university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as these. You can take time to visit our UWIHARP Facebook page as well as YouTube and Instagram to gather more information on what we do and how you can get involved in our activities. Today, Dr. Damian Bass, he is a consultant obstetrician, gynecologist, and a lecturer in the Faculty of Medical Sciences at the University of the West Indies Cape Town campus. He practices obstetrics and gynecology both privately and at the Queen Elizabeth Hospital. And he volunteers right here at the UWI Student Health Clinic for a once-a-month clinic. His subspecialty training is in fertility, and he has established and run the QEH's fertility clinic over the past 5 years. His training is certified by the UWI, the Royal College of Obstetricians and Gynecologists in the UK, and the University of Aberdeen. He published research includes papers on the benefits of weight reduction for improving fertility and on gynecological conditions among Barbadian women. Dr. Bass also enjoys music, and he plays the piano and practices taekwondo, a well-versed gynecologist, I say. Then we have Miss Springer, Nurse Springer, as I refer to her. Miss Springer has been in the nursing profession for over 25 years. She's a registered nurse, a midwife, and public health nurse. She is the holder of a master's degree in public health. Before accepting the post of nurse administrator here at the student clinic over 2 years ago, Ms. Springer previously worked at the Queen Elizabeth Hospital, where her nursing skills were cemented. After which she spent a number of years working in the public health system. Ms. Springer has a passion for teaching, and she has contributed to this field by coordinating and lecturing in the community health and community mental health program at the Barbados Community College. Her life motto is to do unto others as you would have them do unto you. So you can see today we have two experts in the field as we seek to discuss a topic that many persons don't like to speak about, but one which we should, as it affects many people, if not directly, indirectly. Today we will be looking at menstruation under the theme, Know Your Flow. Identifying and achieving a healthy menstrual cycle and managing complications, a big theme, but we're hoping that we can cover everything and give you some feedback, some guide as to how you can seek to have a healthy menstrual cycle. And if you are experiencing pain or discomfort in any way, what you can do to seek relief or to get help. Having a menstrual cycle, it can be a chore for some, it can bring anxiety, it can bring discomfort or even pain, preventing some from experiencing life, from going to work, missing milestones, all these things. And we're hoping that in this discussion today, we can get some guide as to how we can seek relief. So let's just go straight into discussion. I will start with Miss Springer. Can you just give an outline as to what a menstrual cycle is? We know that it starts around 10-9 when you start puberty, just give us a guide as to what really happens in the body and those types of things. Does everybody start at the same time? Do they not? Why not? Those types of things. So over to you.
Okay, thank you so much. Well, let's say that first of all, when you're as a female, somewhere between the age of 8 and 16, averaging age 12, that's when a female would normally start to have their menstrual cycle or menstruation. And that will, from the time that lady starts, that will go for many years up until somewhere around 51, 50, between 50, let's say between 50 and 55. And that's when your what we would commonly call your period would stop, and you go into menopause. But there are so many things that happen in that period. First of all, when we talk about the menstrual cycle, we are actually talking about that first day of your menstruation to the first day of the second of the other menstruation that you get. So it normally would last somewhere on average around 28 days. However, persons can have that cycle lasting from 21 to 35, and it is considered quite normal within that period. So straight off the bat, we're saying that it differs in individuals. Every female will not be the same. You will not have the same experiences and so forth. So
you are counting from the first day that it starts to the next time it starts, and that's how you count off your days.
The cycle. That's the cycle.
Okay.
What we call menstruation now, or commonly known the menses or your period, is actually the shedding of the lining of the uterus. Yes. Now, why this happens, now in your body, within the reproductive system, that's what it is called, where the uterus, the fallopian tubes, and so forth. What happens is that you have certain hormones that contributes to the functioning or how the uterus functions. So you have a situation whereby your period will, so you have various phases, and you have whereby you have what is called the first phase, which is the actual menses. That's the actual menstruation. Now this happens because you didn't get pregnant. Usually that whole cycle occurs getting the body ready to have a pregnancy. So it didn't happen. And so your body sheds that lining, and it's in the form of blood and tissue from within the uterus. Okay. That is what will come out. And that's that's the first phase, which is called the menses phase. Now, some literature says it's 3 phases, some literature says it's 4 phases. So if I'm using the literature for 4 phases, then you start with the menses phase. Then you go to what is called the follicle stage phase, and this now is where you have a hormone called estrogen, that is produced. So you have 2 main hormones functioning to help. Well, so let's say 4 hormones, but you have the estrogen, which rises and helps the lining of the uterus to get thick. It's sort of like preparing the uterus for something to happen, for the pregnancy to happen. Okay. But you have that happening, and then you have another hormone also being produced at that time called the follicle stimulating hormone. And what that does is to cause the follicles within the ovaries now, which we commonly call the eggs. You know, you hear people talk about the eggs within the woman, which is the scientific word would be the ovum, right? And what happens is that the follicle stimulating hormone, what that does is helps that follicle to develop a mature ovum or egg. So that's the second phase, which is the follicle stage phase. Yes. And then you go to another phase that is called the ovulation phase, whereby within the ovulation phase now, that ovum or egg that was mature is released into the uterus. And that release happens under the influence of another hormone called luteinizing hormone. That causes the egg now to be released into the uterus. Once that egg is released, the luteinizing hormone that matures, that causes the egg to release, and then you have another hormone now called progesterone. For most ladies, you would hear mainly about the estrogen and the progesterone, those two main hormones, but you do have the other two hormones also playing a very important part within the whole scheme of the cycle, right? So then that estrogen then further helps the uterus to prepare the lining of the uterus, which is called the endometrium, to prepare further for a pregnancy. So if perchance that the pregnancy does happen, then the egg, now the mature egg meets a sperm and fertilizes, then it attaches itself onto that lining that has been prepared by all these hormones.
Okay.
But if it does not happen, this now equates to lowering of the levels of the estrogen and the progesterone, and also causing now the lining will shed and bleeding will occur for the cycle to start all over again. So it's just a cycle going on and on and on and on until you reach what we would consider, what is called menopause, up until that time. So there are lots of activities. There are lots of activities happening within the body that sometimes we are not aware of, and outside it influences us by the hormones also have other effects on us, like, you get moody and anxious and want to eat many things and all of that. These are the effects of the hormones as they function within the body at that time.
Okay, what you have sort of described sounds to me like a healthy menstrual cycle, what we would consider to be quite normal for an average person. And Dr. Bess can jump in here at any time. What is considered to be a healthy menstrual cycle when you have all these hormones coming into play and helping the body to function at its optimum for this flow to come, what we will call a period. But what happens when these things don't work the way they're supposed to be? When an individual then has an abnormal cycle, is it that the hormones are affecting it that causes it to be abnormal? What brings it to that stage for it to be complicated or abnormal? Is it the hormones? Is it your surroundings? What is it? Now that we've heard what is a healthy menstrual cycle, let's look now at the characteristics of what would be an abnormal menstrual cycle.
Right. I hope I can just add just a few more tidbits about what might constitute normal, so that we can, easily contrast that with things that might be considered abnormal. So we've got established the parameters of the hormones and the ebbs and flows, and how those hormones affect the uterine lining and the cyclical, shedding once a month. I would say that you would expect that the amount of blood loss, it shouldn't be excessive.
Okay.
Published literature would say usually around 50 milliliters. So anything more than 80 milliliters or something that's going to be causing you to have, lots of clotting and, frequent changes of pads, maybe even flooding, soiling, and things overflowing, that's going to be excessive. So any amount of bleeding that is in excess of what the woman would consider, I guess, socially acceptable and reduce her quality of life is going to be called heavy, basically. So that's probably the first main abnormal menstrual characteristic that we could mention now, heavy menstrual bleeding. There might be situations where what Ms. Springer has described doesn't occur in terms of ovulation and so on, and the lady might recognize that her period hasn't come, so she's getting periods of, infrequent periods. So usually within the parameters of every 21 to every 35 days is acceptable. That's accepted as a monthly cycle. Menos meaning monthly, of course, right? So if we're having anything more frequent every 21 days, polymenorrhea, so enough periods, that's probably a sign of the lining not getting that signal, that progesterone signal from ovulating, and that's not being mature. So basically it's doing what it wants at that point. So the estrogen causing the thickening, but shedding becomes irregular at that point. But on the flip side, some women might realize they don't see their period for months at a time, again, because not ovulating, because it never gets that signal to withdraw and to have a period. So it didn't get the I am pregnant serial, signal from not having ovulated. So you'll find those kind of extremes with very frequent periods, like every 2 weeks, say I had 2 periods in a month, or I had a period like 3 months, or I had 3 periods in a year, as extremes where you might not have ovulated. So polymenorrhea, enough periods. Oligomenorrhea, very few. Amenorrhea. Amenorrhea means no period. So you might not have seen the period for 6 months, thinking, could that in fact be a hormonal issue, not having ovulated? The most common cause of these kind of extremes is usually things like the polycystic ovary syndrome or PCOS.
Yes.
But with amenorrhea, oligomenorrhea stuff, also consider sometimes things might be, I guess, structurally wrong if you've not seen a period before as well. But if you've had periods beforehand and maybe something has happened, like, I don't know, miscarriage, you had a DNC to scrape out things and that kind of thing, that can sometimes damage the lining and you might not see a period following that. So yeah, the frequency of the period is important, and very frequent or very infrequent periods kind of go into the realm of abnormal. I felt as though you were leaning earlier towards you wanted to talk about painful periods.
But that's how people kind of describe them, they may have infrequent periods, but they may not say as abnormal, but they may have them but have pain. So I just wanted to touch a bit on that.
Absolutely. I get you. I always have to clarify with women when they come in and they say, boy, doctor, my periods, bah, 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 bah. So it's like, what are they heavy or what? Very often it has pain. So we call that dysmenorrhea, right? So painful periods, dysmenorrhea. And so there are different causes for dysmenorrhea. This the type that's called primary dysmenorrhea. Think about primary school, secondary school, primary, from the beginning, right? So you start having your periods and, a few months, 6 months, a year later, your periods start to get painful and there's no anatomical reason for that. It's not like any fibroids or endometriosis or anything like that. There's no anatomical reason. You call that primary. And that tends to be due to the release of small little hormone things like what they call prostaglandins as a response to maybe ovulation or the bleeding from the blood vessels in the uterus and so on. And as a result, things that block the production of prostaglandins, like, your non-steroidal anti-inflammatory drugs, people know ibuprofen, Advil, people know Voltaren, diclofenac, Advil, Voltaren, Cataflam, right? Those actually are pretty good when there's primary dysmen because they block the production of those prostaglandins. Yeah. Similarly, if you can stop
adults, not to cross you, those are medications that can be used for adults. What about younger, like teenagers?
Children can use them too. The doses are just adjusted, right?
Awesome.
Yeah, people like to reach for Panadol, paracetamol, Tylenol. Kind of
I
more second line.
I'm not sure if that's still famous.
Yeah, and that's supposed to be
antispasmodic. Probably mild dysmenorrhea may help.
Yeah, I remember Baraldins for years as a teenager. So yes.
Yeah, and you don't be afraid to mix the classes, because sometimes that can afford you relief where, just taking a one mefenamic acid, Ponstan, or non-naproxen or something. You take some paracetamol on top of that because it's a different mode of action. It can give you additional relief. Okay. But the oral contraceptive pills, the ones that have an estrogen and progesterone, like microgynon is a common one. I like Yasmin, those kind of ones. By inhibiting ovulation and by also helping with that maturation of the lining of the womb. And similarly, by mimicking how the natural cycle goes, you can find that those are a kind of over-the-counter and easy self-applicable solution to many of the irregular period or the painful period problems as well.
Okay.
Right? And incidentally, those same classes of non-steroidal drugs can reduce the heaviness of bleeding as well. Yeah.
Awesome. So well, we talked about pain, we talked about the frequency, we've talked about feeling
you might want to also mention, premenstrual syndrome. You've heard of that one?
No, I haven't. So enlighten me. What?
Yeah.
You mean like the cravings and so on? That's what you're referring to, premenstrual?
No, you're familiar with premenstrual syndrome, Chloir?
Yes, that's where you can have pain and stuff like you're having a period prior to the period. It happens a couple of days before your actual period, you're in pain.
Yeah, so there's a bit more, I guess, stuff surrounding the premenstrual syndrome in terms of, if you're hearing, I mean, most women will get a few things as a result of having ovulated, like a little bit of bloating, a little bit of, maybe mood swings and so on. But if you're getting that cluster of symptoms on a monthly basis and maybe a bit more severe, then that constitutes premenstrual syndrome, right? So they will get, breast discomfort, again, bloating, feeling heavy. They get maybe some, depression, mood swings, and sadness, and then they have some pain. Yeah, so abdominal pain probably not as common, but maybe nausea.
Yes, some people get vomiting and nausea.
Yeah.
Well, I'm familiar with what you're saying, but I didn't know it actually had a name.
It does, and I suspect that it's probably underdiagnosed because people are aware,
I think people think it's normal.
Fog. You never brain fog around that time. They can't remember what they're thinking about. Insomnia, all these things happen as a result of, they think, imbalances in certain hormones like serotonin and GABA, which is gamma aminobutyric acid. But certainly the key event seems to be ovulation and that rise in progesterone. So some different women will respond differently, and obviously some will have more severe forms, premenstrual syndrome. And the ones that really have this bad psychological, issues where they're, depressed, fearful, maybe even, anxious and so on. There's a severe end of the spectrum called PMDD, or premenstrual dysphoric disorder. So yeah, more common than you think. And basically, this is one of the things that women can do, certain things to help themselves, because it doesn't necessarily need to see a doctor or a gynecologist. It's been evidence to show that things like, simply addressing your diet, your exercise, your rest, relaxation, massage, that sort of thing. Certain supplements like vitamin B6 seems to help a lot. And things like, hear this one, if you like herbs, Vitex, Agnus castus, Vitex, right?
And the local word for that is?
Yes, that's Vitex. That's Vitex. It's called Agnus castus, is kind of chasteberry tree, so that's where they get it from. And that partly helps very well with premenstrual syndrome. And similarly, by preventing ovulation, birth control pills have been used to help with PMS as well, particularly the ones that contain drospirenol, so Yasmin. But Yaz, Yaz, that's the one that is meant to be actually licensed for use for premenstrual syndrome, because what it does is it has a lower dose of estrogen. It has in that drospirenol, which kind of helps to reduce the bloating and the other signals that cause those kind of symptoms.
Yes.
But importantly, unlike most pills that have that sort of 21 active pill and 7-day break, it gives you a shorter break. So you have 24 active pills and a 4-day break. So you actually have less time where you're having that withdrawal of hormone. So it tends to work well for people that have symptoms which relate to a lengthy hormone withdrawal, a lengthy period. So Yaz with a 24 active pill and four pill break, that's the one that's for PMS.
Question though, in taking those kind of cyclistic pills and so on, at any point can you come off and the period then becomes normal on its own, or do you have to stay on it for what happens? Does the body start to regulate and gets its own cycle, or do you have to stay on it for like, I don't want to say ever, but
I have my take on that, but I'm happy to hear what Miss Springer has said on that. As a woman, I don't know if you've ever been on.
I've tried oral contraceptives, and they certainly did not help me. They made me feel very ill, so I just forgot about them. I didn't like the feeling that I got. It made me felt every day. I thought that I was pregnant many days.
Oh dear.
Okay. Oh dear. So, right. So my answer to that is always right.
Got rid of it.
The pills come in different formulations for a reason. You need to kind of tailor the pill to the woman. If she getting too much nausea on a pill that has in 30 micrograms of estrogen, you find one that has in 20. If she's having, acne and hair growing and all other places because she's taking something that has in, I don't know, levonorgestrel, you switch to one that has a testosterone blocker. So you might not have found the one that worked for you.
No, I didn't. I don't think that we spend that length of time, because for me, after I experienced that I was like, I am finished.
Yeah.
So I didn't give the doctor time to see what would work best for me.
So what I would say, Kelly, in terms of my take on if you come off and you can get better, I suppose it depends on the underlying condition and etiology and what other things you've done alongside taking the pill in order to help, right? So for example, take the polycystic ovary syndrome, right? So polycystic ovary syndrome, PCOS, people always know about all these follicles in the ovaries and stuff. The typical features would include abnormal periods, which are the irregular ones like we're talking about, either very frequent or very, very infrequent because of not ovulating. And then they might also have some features of raised levels of testosterone or other similar hormones. So they might have the acne, excessive hair, and so on. Right. So they might have obesity, and all of that goes along with the natural history and the natural underlying causes of disease, which they think it has to do with your body not being responsive or being resistant to insulin. And so the insulin levels are high, so everything else all out of whack, all the hormones are out of balance, right? So first line treatment for PCOS, now regardless of if you're trying to regulate your cycles or try to get pregnant or try to help your hirsutism or your acne, always is trying to reduce your body fat, because that is going to increase your insulin resistance and reduce a lot of the symptoms. So if you're taking the pill but you're going to the gym and you're hitting it hard, and you're cutting out all of the processed and maybe carbohydrate rich foods, and you're finding that you're cutting your body fat and this lifestyle changes have reduced your insulin resistance, you come off the pill, you might find that things are fantastic, Similarly, again, with the natural remedies for the premenstrual syndrome and so on, you come off the pill and things are fantastic. But what might not be the case is if, for example, if you have a secondary dysmenorrhea, which is the painful periods due to underlying condition, like endometriosis is probably a common one, where they have abnormal deposits of tissue like the lining. Other places in your abdomen which respond similarly to your cycle have nowhere to go, because that's supposed to go through cervix and vagina, but it's inside the pelvis. So where does it go? It stays there. It causes pain. So using the pill, probably more continuous and not having breaks, can suppress that disease and make periods less painful. But of course, because it's not treating the underlying disorder, it's not getting rid of it, there's no cure for endometriosis, potentially they come off, or maybe even they're still on the pill and they might find that they don't get as much relief as they used to. So yeah, endometriosis is a tricky one because very often, you know, first line medication might not work. You switch something else that might work, but it might not work. And
Yeah.
there's lots of different modalities. It's really a difficult disease to manage.
So it causes the body to react different every time, because I know I have a friend who actually is trying to manage it. She's changed her diet, she's exercising, she's doing all that she can to,
Yeah.
well, she said she has to keep the weight off, but it's just so hard, you know. And she said even if she puts on a little ounce of weight around her tummy and so on, it is very, very painful. And she says she feels it. I don't know what she's feeling on the inside, but she says it is very uncomfortable. She's changed her diet many times. She's on medications. She's doing a lot of fitness routines. And so even sometimes to the point where she damages some of her body when she's trained, because the weight is just too much on, it just comes on like really heavy and then it goes. And so I mean, these things have been around for so long. I'm just wondering how come, you know, there isn't some kind of
cure.
Yeah.
I feel you. I feel you.
I mean, it is, women go through this all the time. I mean, some people just can't even go to work because of it. It's really, I just can't get it understand. And that's what is really baffling to me, that with all the science and research and so on, we're still at square one when it comes to understanding these biological things that affects the body in adverse ways. And I just wish that there was a way that we could somehow help them. It's really painful watching them go
it can be very debilitating, you know?
Yes.
Yes, for some, yeah.
Yeah, so I know, because I know coming up as a young girl, for me, I still hate them. But in primary school, you know, I had to stay home and so on, going through a cycle. It's just, but we all thought it was normal. And I say I was very friendly with Baralgians. They were my friends. They helped to some degree, but then it just seems as though your body get accustomed to it and you had to find something else. But I don't think that your body should have to go through all these changes just because it has to shed the lining. You know, it has to be an easier way. It has to be a manageable way, you know, to deal with it all. In a way that makes sense, because you still do have to function. And I know Dr. Bessie can say you can put all these things in place, but you know, the body just does what it has to do on its own, because you're dealing with hormones and you're dealing with all these other things. So yes.
Yeah. And I'm sure that this obviously still remains an area where much research is needed, you know, to see what is the next best step and how we can treat the issues that are at hand. Because then sometimes for some to be able to actually manage, you actually have to have major surgeries to actually alleviate the problem, to get rid of the problem, to get rid of all the heavy bleeding and all the severe pain. And of course, these are women who would have been battling with this for very long, because it's not immediately that you will say, okay, you're having pain, you have endometriosis, you have, you know, fibroids, let me just take out everything and finish.
Does that help? Because in some instances,
right.
It doesn't always. You go through that surgery and, you know, it's something else, you know, the underlying cause is still there. So
that is why
mental breakdown, depression, all of that. I've seen it, and it's like you go through all of that hoping for something grand, you know, you're going to experience a little relief, but it seems kind of worse at the end. So
that is why
it's different for white people and for Blacks and Caucasian. I know it's different all across the board, but I'm just hoping that science, doctors out there can come up with something. Yes. But I mean, we've covered so much in so little time. We've talked about what's a healthy menstrual cycle, what we consider to be abnormal or complicated. We've talked about ways in which people can seek relief, which is through the various medications, whether over the counter or going to your gynecologist. And there are some that are for teenagers and so on that you can look into. I know Dr. Yarbrough, she is an adolescent gynecologist for those that will be watching that have children that are experiencing pain. We have Dr. Best. We talked about exercising, diet, all these things that help, but we know that sometimes it doesn't always work. But we just want to encourage you to keep at it. And if you do need more information on this topic, you can always reach out to Nurse Springer, who is located in the Student Health Clinic, and we have Dr. Damian Best, who is attached to the Faculty of Medical Sciences here on campus. So I'm just going to give you both the opportunity to give some closing remarks, some closing points to those persons who may be experiencing or going through menstrual challenges, anything that can encourage them, anything that you want to leave with them at this time as we close.
Okay, so I just want to say that just remember that every woman's body is different, and so you will experience your menstrual cycle different. It is best that you know your body so that you can get familiar with it, what's happening, what's the norm, and so on, that you'll be able to identify when there is a problem or if there's a problem. And of course, if you aren't sure, reach out to your friendly gynecologist. I'm going to say, see Dr. Best. I am sure that, as he alluded to earlier, working from his comments, he obviously is someone that is willing to try to work with you to see what can help you best. It's not just a matter of, well, I can't do anything for you, whatever, but to see what we can do to assist you, that you can be, that the pain can be alleviated or that discomfort, but also to those alternatives without reaching out for medication, using the hot water bottle and the exercise and the meditation and all of those things. You can practice those to help. They help in some form to give you that ease that you need. But we do really hope, because I understood what you were saying, Kelia. Been there. It was not very nice at all.
You don't want to be on medications for the rest of it until you reach that stage of menopause. And I'm sure that even at that stage, you would then have to go through some other kind of complications because of how your body goes through those stages as well. So I mean, if we can kind of get it under some kind of control, early, that I believe that will help in the coming years. The coming years.
Yeah.
Dr. Best?
Well, I think Nurse Springer did a pretty good job of closing remarks. Thank you so much. Thank you guys for inviting me to come to the podcast with you. Yes, I made women's health my life's passion and my life's work. I do volunteer at the Student Health Service Clinic. So, if any of our student body requires gynecological services free of cost, they just need to reach out to Student Health Services. They can make an appointment with me. I'm also at Queen Elizabeth Hospital through referral system, or I'm in private practice as well. And my campus email address, damian.best@kphil.ue.edu. I'm open to answering brief questions and so on. Yes, that was a good one about the hot water bottle, Chloir. I forgot to mention that.
Yeah. That didn't work for me, but I'm sure it worked for some.
It helps for some. And that's why, remember, because we said that it's different. So you have to try different things to see what makes you comfortable.
I agree. Yeah. I thank you both so much. This is a topic that can go on and on and on, one that needs to start very early, even in preparing young teenagers for when it starts, not waiting until they see the first one, then having to explain, what the body is going through and everything else. And I'm hoping that the information that was shared today can help parents and even sisters and persons on campus that have people that are experiencing pain to know what to do in instances like this. Even people that may be stopped from doing exams just because of painful periods or something, there is a way, and you have the resource here at the Student Health Clinic to assist you in those steps. So thanks again for your wealth of knowledge. And you are part of the UWIHARP family by now. You should know that. You always reach out, and we're very thankful for that because you do always share a wealth of knowledge, and we do look forward to partnering with you again in one of our other series. So thank you all for viewing today's SHAD podcast series. We will share their contact information with you in the coming slides. So if you have any additional questions, do feel free to contact us, and do have a good afternoon.
Good afternoon.
Bye. Thanks for coming.
Thank you.